We have with us today Dr. Sushma Bhatnagar, who is the president of the Indian Association of Palliative Care since 2018. She's the chief of Dr. B.R.A. Institute Rotary Cancer Hospital at AIIMS, Delhi. She is also the professor and head of the Department of Onco-Anesthesia, Pain and Palliative Medicine at IRCH AIIMS, Delhi. She's a founder of the Cancer Treatment Center Project for Pain-Free India. She was also the former chairperson of COVID services at both NCI and AIIMS, and a former chief editor of the Indian Journal of Palliative Care. Very warm welcome, Dr. Sushma. And now I'd like to introduce also our speaker for today, Dr. Savita Butola. Dr. Savita ma'am is a chief medical officer at the sector headquarters at BSF Panisagar at Tripura. She is also the secretary of the Indian Association of Palliative Care since 2018, a senior tutor with the Cardiff University, a mentor with the Commonwealth Scholarship Commission, a national faculty of the IAPC, and a member of the expert group with the Ministry of Health and Family Welfare for the Government of India for the National Program for Palliative Care. And she's also founding member of eHospice India. And I am Archana, and I will be the moderator for today's session. So I would now like to welcome Dr. Sushma ma'am to welcome the gathering and say a few words.
So thank you, Archana, and good evening, everyone. I am so happy that today we have started a very absolutely a new but wonderful initiative in which Indian Association of Palliative Care jointly with the online teaching program of Clirnet launches a series of webinars on palliative care. Through this initiative, IAPC really wants to reach to the clinicians and volunteers. Those mainly are working in non-palliative care field, and we will mainly focus the organization like the Indian Medical Association, Doctors, Indian Association of Pediatrics, Indian Association of Obstetrics and Gynae, and maybe Indian Association of Head and Neck Oncology, and so many associations where palliative care is needed, but they are deprived of learning the basics of palliative care. So through this webinar, we will try to reach out to these organizations so that they will understand what the importance of integration of palliative care. Mostly we will be keeping these lectures basically not because we don't want to make them a specialist palliative care, but definitely basics of palliative care definitely everybody should be knowing. And I'm very happy that first lecture we are starting with the introduction that what exactly it is, what exactly this meaning cure sometime, but comfort always. We keep on talking in various lectures, but we don't understand the meaning most of the time. For how a palliative care can help in your thought process of cure sometime and comfort always. And I am very happy that Savita is taking this lecture, and I know that she will explain you in next 40-45 minutes what exactly it is, and then we will have question and answer which Archana will moderate. Thank you very much, and you all are welcome to join this new initiative of Indian Association of Palliative Care and Clirnet. Thank you.
Thank you, Dr. Sushma. I would now like to welcome Dr. Savita ma'am to kindly deliver the presentation for today.
Thank you, ma'am, for the welcome, and thank you, Archana, for moderating. Thank you, Clirnet, for giving us the opportunity to work with you and reach out to non-palliative care community. And I would especially like to thank ECHS today because a lot of the ECHS doctors will be joining. And I would like to say that this is just an introductory session today, but we are going to have a series which is going to be specific for each branch, starting with ECHS. So welcome to everybody. And now I'm going to start my presentation. I hope the electricity will not go while we are doing this. And just, Archana, you have to tell me whether you can see my slide now.
Yes, yes, ma'am, we are good to go.
Okay, thank you. So, dear friends, we will be talking about the power of palliative care in our everyday work. And to start with, I'm going to use this quote by Hippocrates, which says that to comfort always is possible, even though we may not be able to cure the diseases. And palliative care, the word palliative pallium comes from a word which means cloak. And to quote the Quran, it says, "May you be cloaked in tenderness, my brother, as if in a cloak." So palliative care has the underlying philosophy that people who are going away from this word deserve the same kind of loving, tender care that we reserve for the newborns. What does palliative care do that is different? So palliative care looks after the quality of life, not the quantity, but the quality of life of the patient. It looks after not just the physical suffering, but also the other aspects of a person who is ill. It treats the person as a whole. So when we talk of a patient on bed number 26, a breast cancer on bed number 26, we have to remember that there's a person who is attached to that cancer. And this is perhaps the only branch of medicine which treats the patient and the family as one unit. The WHO defines palliative care as an approach that improves the quality of life of patients as well as families who are facing the problems associated with life-limiting illnesses through prevention as well as relief of suffering, early identification, good assessment, treatment of pain, as well as other physical, psychosocial, and spiritual problems. The main features of this approach are that we do not think of death, but we think of life, living as actively as possible until the patient dies, with the help of a multidisciplinary team, involving the families and the patients in joint decision-making. Like all other branches, this branch also respects life, but the slight difference is that it accepts the inevitability of death. Although palliative care started with cancer patients, it has now grown to look after patients with organ failures, HIV, MDR, TB, neurological illnesses, paraplegia, hemiplegia, pediatric conditions like cerebral palsy. That's a huge group which needs care in India. Patients with congenital anomalies, as well as those who are frail and geriatric patients having dementia, Parkinson's, or Alzheimer's. One myth about palliative care that many people have is that it is just terminal care for cancer patients. That is not true. Palliative care ideally should begin from the time of diagnosis. And as you can see here in this diagram, when the patient is diagnosed, there may be just counseling which is required, but as the illness goes on, and if it's an incurable illness, then there comes a time when the treatment is not going to work any longer. Then the treatment part, the curative part stops, and there is only palliative care. So till this time, they go on side by side, till there comes a time when there is only palliative treatment required, and it does not stop at the death of the patient, but continues in the form of grief and bereavement support for the family which is left behind. The Lancet Commission report on pain, palliative care and pain relief in 2018 developed a new conceptual framework which measured serious health-related suffering in 20 health conditions which are responsible for most of the adult and pediatric deaths. And it projected that almost 40 to 80 million people all over the world need palliative care, out of which almost 80 to 95% people live in low and middle income countries. All over the world, just 14% of people who need palliative care are able to get it. And further analysis showed that this need is maximum in case of older patients, in females, and those who live at home or in nursing homes. But the need in India is even more. NCDs are responsible for almost 66% of the total deaths in India. These affect a younger population than in the West, when people are still earning. They are in the economically productive years of their life. And out of the cancer patients that we have every year, almost 1.1 million cancer patients, 80% of these come when they are incurable. Of the 8 million deaths we have in India each year, almost 6 million people need palliative care. And a very, very sad fact is that less than 2% have access to good terminal care. Now, where can palliative care be delivered? It can be given at hospital. It can be given in a hospice, which is a special place for the terminally sick patients, but it can also be given in daycare, in the community, and at the patient's home. Now, home care is very specifically convenient for both patients and caregivers, because it can be individualized, it can be tailored to meet the needs of the individual patients. Patients are comfortable, families are comfortable, and for a person who is dying, their loved one feel that they are still able to do something. For a mother who is holding a dying child, just to be able to give them a bath, or to be able to make some porridge or khichdi for them at home and to feed the child with her own hands is very comforting for the mother. And this also has the best level of evidence in research. So when the treatment advised in all the chapters of the textbooks fail, is there nothing more to be done? Sometimes we tell the families कि आप patient को घर ले जाओ, हम अब इसका कुछ नहीं कर सकते हैं, आप घर ले जाके सेवा करो. So what exactly needs to be done? Palliative care is that missing chapter. And the underlying philosophy of palliative care is that we never say to the patient or the family that there's nothing we can do, because there's always something that can be done to make them comfortable and pain-free. This concept is not a new concept. It was there in India in the olden days, even in Ashoka's time and in Varanasi, where people used to go to die. And in Ashoka's time, there were viharas which were looking after the sick and the dying patients. But the modern concept of palliative medicine was given by this lady, Dame Cicely Saunders, who was initially a nurse and then a doctor working in the British Army in World War II, looking after the sick soldiers and the dying. She did a lot of work with the dying as well as with morphine for pain relief. And she had a theology background. She came out with this new concept, which said that the dying need good care. From UK, this concept spread all over the world and became an integrated part of the healthcare systems in Europe, USA, Australia, and in Africa. When the AIDS epidemic started, lots and lots of people needed this kind of care. Uganda stands out as an example. I have put it in red because it's one of the poorest countries, poorer than India, which has been able to give excellent palliative care to its people, even in the remote areas, by empowering the healthcare workers, especially the nurses. So WHO says that access to pain and suffering is a human right. Access to pain and suffering relief is a human right. And that this is an essential part of healthcare, which should be accessible in all the countries. For this, the World Health Assembly passed a resolution in 2014, and it's part of the Sustainable Development Goal 3 under the Universal Health Coverage. The model that is advocated by WHO is the public health model, which says that good policies, education of healthcare workers as well as beneficiaries, good drug availability, especially opioid analgesics, and developing the services with an integrated approach to whatever services are already present in the country is the best way to develop healthcare for palliative care, which can reach the remote and peripheral areas also. In India, the WPCA Global Atlas of Palliative Care says that we are still in the level 3B, which is the generalized palliative care provision, but we are yet to reach the integrated level, which are seen in the developing countries. In India, we started initially in the 80s with GCRI at Ahmedabad, then Pain and Palliative Care Society came up in Calicut in 93. The Indian Association of Palliative Care was registered in Varanasi in 94 with WHO and Government of India consultation. The Home Care Network and Support came up in 97. And Kerala was the first state which had a health policy related to palliative care. It included in NRHM. Community involvement with the best coverage in Southeast Asia is what this model stands out for. And micro donations, which raise 70% of the funds, are given by the community. Today, we have 3 WHO collaborating units, which are there in AIMS Delhi, IPM Calicut, as well as Pallium India. The MD medicine and palliative medicine started in 2012, and we also have a DNB program since 21. It has been included in our national health policy since 2017. So that was all about the global picture, but what exactly does quality of life mean? It means different things for different people, depending on their illness and where they are in life. It's not just the physical suffering, but it's also the psychological, the social, and the emotional well-being of the patient and the carer that need to be looked at. But as Kabir says, bhuke bhajan na hoye Gopala, so unless we take care of the physical symptoms, it's not possible to take care of the other things. A patient who is in pain cannot think of anything else. They cannot sleep, they cannot eat. Pain is now designated as the 5th vital sign. And patients have, we are all aware of the physical symptoms that are there in chronic illnesses: respiratory distress, delirium, loss of sleep, loss of appetite, as well as sleep disturbances. But what we also need to remember is the 6th vital sign, which is the emotional distress. Whenever a person is told or they learn that they have life-limiting illness, when they are going to die, or there's a recurrence of cancer, then the shock, denial, anger, all these stages that a person goes through, apart from the financial worries, the anxiety and the depression, these are what cause probably more suffering for the patient and the family in developing countries. Nursing needs, we tell them, ghar le jao, seva karo, but what exactly do they have to do? When a patient has to be given a bath bed, a patient has to be transferred from the bed to a wheelchair, families don't know how to do it. So palliative care takes care that we teach the families when we send them home. We teach the caregivers how to do catheter care, how to give a bath in the bed, how to do mouth care properly, and with things that they can use with low cost, not adding to the spiritual issues that patients have is much, much more. They will come up with many difficult questions. Why me? Why has it happened to me? Have I done something wrong? Was my karma bad? If a child is dying, a 1-year-old child is dying, and the mother asks, मैंने ऐसा क्या किया था जो मेरे बच्चे को इतनी तकलीफ हो रही है? How do we explain that? We are not trained in medical college to answer these questions. A patient asking, will I be staying long enough to see my daughter married? These questions we don't know how to answer. But should they be told the truth? Should patients know the truth if they are dying? Lots of studies are there and a lot of evidence says that yes, patients want to know the truth and that they should know the truth, because once they know, they will have the power to decide correctly and they will be able to make the right decisions about what they want to do with their life. So good communication skills are very important. And it is said that doctors, there was this landmark study in 1984 by Beckman and Frankel, which showed that when a patient comes for consultation, the doctors interrupt just 18 seconds into the consultation. And they did some training for good communication, after which their period of interruption increased by 5 seconds. So they started interrupting at 23 seconds. So good communication skills, listening is very important. And communication, we come to know in palliative care that it's not natural. We can all learn good communication. It's a learned skill. So how to tell, how much to tell, when to tell, breaking bad news, and how to balance that hope with truth. How to tell them sensitively, in language that they can understand, and understand whether they have really understood what we have said, because in a country like India, you have a huge number of languages and different cultures. So you need to check their understanding also. And talking of children in palliative care, these children may be patients themselves, they may be siblings, or they may be the children of patients. And though we all love children, we tend to ignore them. Especially in Asian cultures where we think that children do not need to be told, but children are much, much more sensitive and observant than we give them credit for. They understand so much more. So palliative care also teaches us how to communicate with children in language that they can understand at their age, their concept of grief and death, and how to explain things to them, how to involve them in the care of a patient, then how to manage if they are themselves sick or if a loved one is sick, and how to deal with that grief and loss. And we all know that in our cultures, spirituality is very important, but are religion and spirituality the same thing? No, they are not. Palliative care teaches us that difference, and we also understand that spirituality becomes even more important. It's an important part of life for everyone, but for patients who are suffering and for families who are suffering, religion as well as spiritual practices can help them sustain in times of distress. And as palliative care people, we should know how to elicit their needs and how to put them across to people who can help them meet their spiritual needs. So counselors and preachers are all important. And a little bit about pain now, because pain forms the entry point for most palliative care patients. It's present in almost 2/3 of the cancer patients, 80% of hospitalized AIDS, as well as almost half of the cardiac patients, and 70% of patients who are dying suffer agonizing pain and distress, but less than 4% patients in India are able to get proper relief. And for patients who have to watch their loved ones suffer, they think it's better to let them go. Mukti ho jaye to zyada acha. It's very difficult to watch their loved ones suffer. But unfortunately, pain remains undertreated, unrecognized, incompletely assessed throughout the world. And there are lots of studies that show that doctors, they fail to appreciate the severity and to address it in most of the cases. And there is no quantitative numbers that can convey the suffering that patients and families have to undergo. 1 out of every 5 suicides in India is by chronic illness patients, and the risk of suicides is increased by 20% in cancer and almost 100% in case of unrelieved chronic pain. I'm sure you have all seen this news when the police commissioner of Bombay, Himanshu Roy, he shot himself because he could not take the suffering and the pain that was associated with his cancer. So Dame Cicely Saunders also gave us the concept of 3 dimensions of pain. She said pain is just not physical, it is spiritual as well as psychosocial. So palliative care teaches us to deal with all the concepts, all these dimensions of a patient's pain. And when we are talking of chronic cancer pain, we have to talk of opioids also. Pain relief, as I said, is a fundamental human right. And if we are not able to give them access to pain relief, it is just as bad as torturing somebody. And the developing countries of the world, which have most of the patients, they are not able to have access to the opioids. India is the biggest legal producer of morphine in the world, but we have very little domestic consumption in spite of the huge burden, because we don't learn about it, we don't learn how to prescribe it, and it's mostly exported because of the low demand. And the laws in 84 had been very stringent, so that 2 generations of doctors grew up without using morphine, oral morphine. And it's now that the laws have changed and it has become easier to get morphine into an institution and prescribe it. WHO gave this analgesic ladder way back in 86, thinking that 80 to 90% of chronic cancer pain as well as other pains will be able to be managed with this, and they still can be, but there are very few people who are trained to use it properly, and we still need to do a lot more about teaching pharmacology of opioid analgesics for analgesia. Most of us read it up in terms of addiction, but a UN resolution in 2005 stated that morphine should be available at all times in appropriate dosage and forms in all healthcare centers, and that low national consumption of opioids is a matter of great concern. So for India, how concerned should we be? If you look at this, 80% of people who die of cancer, 50% of those dying of HIV, they need almost 679 milligrams in the last 3 months of life. And how much are we using? 0.4%. It's really, really very concerning. And if you look at the global consumption, then Austria, US, UK are here at the top. And for India, you have to look really, really hard to find India somewhere at the bottom. Why does it happen? Lack of education, lack of knowledge. There were very stringent laws, as I said earlier, but patients are also reluctant to communicate pain and to take opioids. I know people are here from the army background, people are here from ECHS, and I'm sure you all know how difficult it is to get our people to talk about pain, because they are trained to take pain in their stride and they will not talk about it. But there are also problems in manufacturing, because the pharma companies don't see profit in the low cost of morphine. Morphine is very, very cheap. If you look at here in the table here, you see that 1 day's cost of morphine is rupees 5.5 and fentanyl costs 112. So you can imagine, why would farmers be interested in writing morphine? Because we are not writing enough, so they are not making. And the biggest reason for our not prescribing is that because we think of opioids only in terms of addiction. respiratory depression, unacceptable side effects. But what is the truth? Do they really cause addiction? Patients who are receiving morphine for medical purposes, there is a lot of research, there is a lot of evidence which shows that this fear is totally unfounded. We need to be careful. We need to document properly. We need to supervise them properly. But it is just like giving digitalis. We give insulin, we give digitalis, we give steroids. We just have to be careful. It doesn't mean that we will not give. So opioids exist to be used, not to be withheld. Oral morphine still remains the gold standard for cancer pain. This is a Cochrane review. And there is also evidence now which says that the WHO ladder, if you go straight away to step 3, you have less side effects than if you use step 2 drugs like tramadol. There was another study in the Lancet, which was done in Calicut way back. Over 2 years, they studied almost 2,000 patients, 1,700 to be exact, and found no cases of diversion. Opioids for long-term treatment of cancer pain. This was a Cochrane study. This again found that minor adverse effects are there, but iatrogenic opioid addiction is rare. So palliative care teaches us good symptom management. It needs excellent skills because our patients have advanced disease, they are frail. But this session, we are having this to tell you that almost 65 to 70% patients can still be managed at the generalist level with good training. And it's only 30 to 35% patients who need specialist palliative care. Those ones with complex symptoms, those who cannot be managed at primary or secondary care level. And the thing is that symptom management is done slightly differently from what we do with other cases. And drugs may be used in different forms or in different doses. For example, in dyspnea, we use bronchodilators, we use steroids, we use oxygen. But what do we do in a terminal case? We use opioids, the drugs that we normally would think leads to respiratory distress. So opioids are the drug of choice for refractory breathlessness in patients with advanced illness and terminal disease. There are many evidence-based studies which show us that this is another meta-analysis which shows that opioids can be used in the management of dyspnea. And there's another thing which I'm sure, which is new for you, that fan therapy, a fan which is directing air directly onto the face of the patient. This has a lot of evidence for relieving breathlessness in the chronically sick patients. And prognostication, this is a lost skill now. With more and more change in the way we practice medicine, it has become more investigation-based, more focused on cure, and we have lost the skills of prognostication as well as communicating that prognosis to the patient and the family. So, but if we know how to prognosticate well, we can never be 100% sure. We have to tell the family that we can only give a range and we should never give specific numbers. But it's important for advanced planning for anticipatory prescription, and it helps the patients and families to take informed decisions. It prevents unplanned hospital emergency visits and futile interventions, and much financial burden can be avoided if patients and families know the truth. So it's not just chronic illness. We have a lot of emergencies to deal with. Hemorrhage, hypercalcemia, spinal cord compression, terminal breathlessness, restlessness. But the underlying thing is that it has to be done in an ethical way, taking care of all the 4 ethics that we are taught. And these are relevant, especially at the end of life care for feeding and hydration of the terminally sick patient. A patient may be so sick, he doesn't want NG tube, it is causing him discomfort, but we keep insisting, no, you have to take that NG tube because we have to feed you. What about IV fluids at the end of life when the patient's family says, please do something, please try everything that can be done. And you know the treatment is going to be futile. Then what do? How do you withdraw care? How do you withhold care? What about ventilation, CPR at the end of life in an advanced disease where it's not going to help? How do we tell the patient and family all that? What about delegated autonomy? What about culturally appropriate care? So all of these things are what we learn in palliative care. And underlying all this is that we are a developing country. We have patients who are poor. And we must not forget that high out-of-pocket expenditure on health results in almost 55 million Indians annually going below the poverty line. Catastrophic levels of health expenditures. This is the WHO report. And there's another study which says that almost 53,000 rupees patients spend in the last 12 months of life. And it has increased, diagnosis and bed charges have increased by 243 and 323% in the last years. From 2015, that decade, they have really increased. And we must remember not to add to the financial pain of the patient. This can only be done if we can prognosticate well, if we can communicate it well. And there is informed and joint decision making with the family. Sometimes we know that it is not going to help, but we don't know how to tell the family. And we must know the cost benefit ratio of therapies that we are advising. And it's something to think about whether it is ethical to advise a treatment that the patient cannot afford, because it will always leave the family feeling guilty. Agar mere paas paisa hota to mera patient bach jata. It's just because I cannot afford that treatment that my patient has died. So when we advise therapies, experiments, trials, we must always remember whether we are adding to the financial pain of the patient. And palliative care, many people think it's just end of life care. It is good end of life care, but it's much more than just end of life care. But it's important because how people die lives on in the memories of those left behind. And what about India? India is not a country to die in, it is said, because consistently the Lion Foundation and the Economist Unit, they published the Quality of Death Index, where consistently we have ranked. In 2015, we were at the bottom out of 40 countries, and though we have increased, but it's still really bad. But then what is a good death? What is the concept of a good death? A good death is where there is adequate pain relief, good symptom control. The patient knows they have had time to evaluate their life's journey. They are reconciled to that fact, and we give them good, appropriate, ethical treatment at the choice, at the place of their choice. Good support to patient and family, help them to settle their legal and financial matters, elicit what they want, how they would want their life to be, how they want to spend the time that they have left, and honor those wishes. Taking care of their cultural requirements, their religious requirements, discuss the place of death and the funeral rites in advance so that we can make arrangements accordingly. And what you see here in the picture is a patient who is terminal and at home with his family. And what you don't see in the picture is palliative care, which can make this happen. There are good models in UK, Australia, even within India, where scientific way of taking care of the end of life is there. And there is also the fact that we have a lot of inappropriate referrals to higher centers, a lot of ICU admissions, a lot of aggressive treatment that happens at the end of life, because doctors generally think that there is a lack of clarity regarding legal guidelines, hospital policies. And we just write Lama and send the patient home, so that patients don't get proper end of life care and they die at home in distress. The families are left grieving, and non-availability of end of life care, it leads to almost 78% of Indian patients leaving hospital against medical advice. This is as per studies. So what has recently happened is that there was a policy statement by Indian Society of Critical Care Medicine and IAPC, which has given good guidelines about how we can withdraw and withhold care or CPR or ventilation in patients who are chronically sick. This is a good paper for everyone to read. And also the concept of advanced care planning, which allows individuals to define their goals and preferences for future medical treatment, and to discuss these with their families as well as healthcare providers, to record them, and to give advanced medical directives, which is a legal document giving outline of all these things, and also to name a surrogate decision maker. अगर आप इतने बीमार हो जाएं कभी कि आप अपना decision खुद नहीं ले सकते, तो who will take care? Who is the person you would want to take decisions? So this was legalized by the Supreme Court in 2018. And now in 2023, January 24th, the Supreme Court has given a judgment which has made this whole process easier to implement. Initially, it was very complicated, but now it has really become easy, and it is possible to do this. So there was another article which I would suggest that we can read to understand this whole process. This gives the outline of withdrawing withholding care for patients who are in the ICU, who are hospitalized. And there are end-of-life policy guidelines which have been published by AIMS as well as Manipal Hospital, which help us to understand how to do this good end-of-life care as well as the withdrawal and withholding of treatment. After the death of the patient, we need to give them privacy, take care of their needs, help them with funeral arrangements. We give them grief and bereavement support for the family, but we also make sure that unused are not burned or buried with the bodies, but they are returned back to the institutions from where they were issued. Ultimately, the idea is to reassure the patient and family that they are not alone in their period of distress and there is somebody to help them. But at the end, just to finish this lecture, do you think palliative care is just social work or we just hold hands and wait for the patients to die? No, it's good evidence-based medicine. There was this article in NAGM which talks about early integration of palliative care for metastatic lung cancer, and which showed that it actually helps in increasing. It showed that compared to normal standard care, palliative care resulted in better survival of the patient as well as better quality and mood. So many research articles are there which show that it results in decreased costs for the hospital. It results in better quality of life. Unexpected hospitalizations are decreased. Patients and families are better satisfied. This is a study of 12,000 patients, which shows, it's a meta-analysis which shows that it is again associated with patients' quality of life and better symptom care. But there are many barriers. Health systems may not allot funds if they are limited in scope, focused on end of life only, or there may be restrictive policies for opioid access. Vulnerable groups may not get proper care. But most of the barriers come from within the profession itself, where people are not aware. People are not aware of when to refer, where to refer. And there is a lot of, sometimes, patients, they don't want to refer their patients because they think it's only end of life care. They're not sure when to send the patient, and perception of death as a professional failure. They don't want to give up. So palliative care teaches us that there is a way to balance hope with good symptom control without thinking of it as a personal failure. And sometimes they may have a difficulty in stepping back in acute settings, for example, a patient in ICU, but with good education and with good training, these can all be overcome. So palliative care and good ICU care or good curative care are not mutually exclusive. There is a lot of evidence now. People who are working in private sector or in corporates want to know whether it is cost effective, whether it helps the hospital. Yes, it makes good economic sense. So there were lots of analysis. This is a review of reviews which shows that yes, it results in reduced costs, almost $2,000 compared to an ICU admission for 5 days. And this is another one which shows that the inpatient consultation programs also result in less cost for the hospital. This is a systemic review of almost 800 eight studies, which shows that it reduces costs without impacting mortality. So you can go through all these papers, but then you would be thinking, how can we help? Where are we sitting? In our own place of work, how do we work it out? So the best thing to do is to identify people who are in need, do good assessment of their symptoms, especially pain, and just like we refer people, if I'm not an ENT specialist, but if I see a patient with a near discharge, I can treat him, and if I cannot treat him, I refer him. So refer to the right place, know where to refer, how to identify. You can have screening tools. There are lots of tools which help us in identifying. One is a very simple question which says, would I be surprised if this patient dies in the next 12 months? And this can also be supplemented with a question, would I be surprised if this patient is still alive after 12 months? Apart from that, this is a screening tool for emergency department. This is a Radboud indicator. This is again another good screening tool. There's a gold standards framework from the UK, which gives general indicators, which gives indicators for cancer, COPD, heart disease, neurological, renal, MND, Parkinson's, MS, frailty, dementia, stroke. So I put them all here on the slide so that you can see them later. There's a supportive and palliative care indicators tool three versions are available for different settings, but there's another version which is available for low-income countries, which we can use in the community. So we can integrate this into our care at all levels, follow up people who have been receiving this consultation, guide families for home care, ensure social and psychosocial spiritual support, but also to convince your administration that it makes good economic sense to have palliative care in your hospital, because it frees up ICU beds for patients who need it most, and that is social justice. A young person who has trauma, he needs that bed more than a cancer patient 85 years old who's already having organ failure and who is not going to be helped by ICU care. That chronic patient can go home and this bed will be given to somebody who really needs it and who can be helped by it. It also improves patient and family satisfaction with your care, and it earns goodwill for the hospital. So it does make good economic sense. The National Program for Palliative Care came up in 2017. It is implemented at the state level for training, as well as through money which is given out through NHM pool, flexi pool, which districts can ask for, states can ask for, and this is a plan how the money is distributed. You can take a look at it later. But what we can also do is increase our own knowledge and skills through many programs which are available. There are good online programs. We should make awareness for other professionals, patients, public, policymakers, and law enforcement agencies, police organizations, because we deal with opioids. They should also know about it. Also train our own healthcare workers, our volunteers in our communities, make sure that we have good networks. If we don't have within our own institution, then if we have a good network of people, we should know where to refer this person. We should tie up with NGOs for home care, involve civil society for advanced care planning, publicity, advocacy, involve media, involve politicians, involve CSR projects for funding. And last but not the least, never think that what you are doing is not making a difference, especially for the youngsters who are there. And I know there are some people here who are really struggling to start palliative care in their own institutions. I would just like to leave them with this message that never doubt that committed people can make a difference. It is the only thing in the world that has ever changed the world. Thank you so much. And now this was my last slide. And these are some references that you can use, and we can take the questions if there are any. Thank you.
Thank you, Dr. Savita, for that presentation. So before we begin, if anybody has any questions or queries, please feel free to unmute and talk to us. Okay, so to get started, Savita ma'am, I think this presentation came along well. Like it started with a global perspective, and then we funneled into a more region-specific context and then we touched upon various concepts, the whole multidimensional aspect of palliative care, and also the practical components. But if like you did mention a lot of the myths, for example, as a starter, somebody who's walking into palliative care, right? You did weave them into your presentation, but if you could touch upon maybe the top 5 or top 4 myths that are existent so that people, as a takeaway, they know that this is the thing, what would you say?
The first of all is that it is for terminally sick patients. So the thing is that it is for life-limiting illnesses, but it should ideally begin from the time of diagnosis, so that when the patients come to us, they have a good rapport with the team. And there is so much more that palliative care can offer. Think of it as prevention. We can prevent pain from happening. We can prevent people from having a painful, undignified death if they come to us in time. Sometimes they come to us 2 days before they are dying. They are in comatose stage, and there's hardly anything that one can do. So late referrals are a problem, but if people know that early care can make a difference, I'm sure patients are going to be benefited. So second thing is, it is only for cancer care. No, it's not only for cancer care. There is a huge number of, in fact, there's a bigger number of people with COPD, CKD, CHF, HIV, cerebral palsy, geriatric population. If you put all these together, it's a bigger number which needs care. Third is that it's difficult to tell a patient that they are dying. How can I tell? What will they think? Patients already know. Half the time when you tell them, their bodies are already telling them. They know from their experience. Sometimes older people, they have so much of experience in their own lives that they can make out a person is dying. They know they are dying. It's just, and most of them will find it a relief to be able to talk about it. Everybody otherwise keeps acting in the family. Everybody puts up a drama that nothing is wrong, whereas everybody knows what is happening. So this is more difficult to sustain. So having an open communication about death makes it easier for everybody in the family. Fourth is that it's not economically viable. So as I said, it makes good economic sense for hospitals to have palliative care. Generally, corporates and private sector people think it will lead to loss. It will not lead to loss. The maximum amount of earning that a hospital has is in the first 3 to 5 days when the patients come in. So if you have a chronic patient taking up that bed, which somebody else can use, it makes more sense for the patient. It makes more sense for the hospital. So we have these 4 myths. Anything else that comes to mind? Maybe Divya, Dr. Sudha, Nisha, can you remind me? Sushma ma'am, कुछ और रह गया? कोई myth जो आप बताना चाहेंगे?
नहीं, आई थिंक मेरा थोड़ी देर के लिए नेट चला गया था. सबसे पहले तुमने बताया एंड ऑफ लाइफ केयर मानते हैं लोग, दैट इज द बिगेस्ट मिथ. देन पीपल थिंक दैट opioid, which is mainstay of pain management, is causes addiction. It is the biggest myth. So I think rest you have covered very well.
हाँ, तो 5th मैम ने बता दिया कि
And
opioids being addictive is
people also think that, and whenever because we don't have a habit of integrating in early stage, so when I'm dying, that's why they have sent to the, so this gives them a very negative message, which is not correct.
Absolutely. And Dr. Savita, would you maybe give an insight to somebody? Because we've always said that, palliative care should start from the time of diagnosis. So maybe with a case or something, an instance on what sort of role palliative care can give at that stage, at the time of diagnosis, so people know that, there is a space for them to intervene and they can identify such things.
Yeah, so thank you. Only today I had a message from one of my juniors, saying that we have had a card test which came out positive for an HIV serving person. So how do I deal with that? He's very upset. He just wants to take medical leave and go. So first of all is good communication skills. How do we break that bad news to the person? When a person is going to learn about the diagnosis, it can be really devastating, especially for a young person, to know that they have a life-threatening illness, whether it's a cancer or HIV, anything. So be able to give that news in a way which is supportive of the patient, which makes them understand things. They feel confident enough for coming back to you, guiding them through that illness. It's basically, planning ahead, which is so important. If you start from the beginning, then you are able to plan ahead. Plan ahead in the sense that you are familiar with the trajectory of the disease. The patient and family don't know. So there will be times when the patient's family, this is again from experience, the family will come and tell you, हमारे को बताया था कि कैंसर बहुत एडवांस्ड है, एम्स में उन्होंने मना कर दिया सर्जरी के लिए, लेकिन एक प्राइवेट हॉस्पिटल में हम गए थे, वहां पे उन्होंने बुलाए कि वो ऑपरेशन करेंगे और पेशेंट ठीक हो जाएगा. सो हमारे पास जो घर में जमीन है, क्या हम उसको बेचते हैं? Will that help our patient? So as a doctor, you may ask for help. So we are talking about generalist palliative care. You may not be exactly aware of whether that surgery is indicated, but then you can discuss it with an oncologist colleague, 2 colleagues, read about it, find out whether it is actually going to help, ask somebody, and then guide the patient accordingly. Because if they sell that land, patient is anyway not going to survive. But they will not have money left for the children's education, to bring up those children, to get those children married, to get them settled in life. So it's very important to especially have that rapport and that confidence, which a good relationship brings, which good communication brings for your patients, especially again in primary care. I'm stressing on primary care. In primary care, you are the primary physician. In India, it's very unfortunate that we have fragmented care. We may have a number of specialists looking after, but there's no one person to coordinate that care which is happening. And the patients and families are left bewildered. They don't know where to go, what is happening. So coordinated care, somebody to guide them through, somebody in charge of the case with good rapport, where the patient and family feel confident that yes, they are going to guide me in a correct manner, so that you are also able to guide them through. As I said, financial issues are very, very important in India. So guiding them in a way, giving without taking away hope, but also to be able to tell them that yes, this is not going to work, so don't waste your money. Right? So all of these things can happen only when they come to you early. If they come to you when the patient is already, as I said, unconscious, or patient is absolutely gasping, there's really nothing much that you can do. Even for pain relief, patient is coming early, you can titrate the morphine, you can put them on a number of combinations, you can try those drugs, but a patient is coming unconscious, you really cannot titrate even the proper dosage of pain relief. There's so much more. Anticipatory planning, as I said, when a person is sick and dying, that is happening with us. When we send our patients home, they come from all over the country. Our troops come from all over the country. So if they come to us early and we know we have to send them home, then we can tie up with whoever is the palliative care person near their home in their regional languages. We tie up with somebody who is nearby, who will be able to give them an injection if required. And people will not prescribe them benzodiazepines or opioids if they are not aware. We take the responsibility. We are giving them prescriptions. We put our seal there and we talk to them on the phone saying that I'm sending this patient. He's in a terminal condition. Please take care of him. If you have a problem, call me. I'm responsible. And we also tell them if a patient dies at home, then how to get the death certificate. There are so many things which, so many complications that can be prevented if the patient comes to us in time. So early integration of palliative care is so, so important.
Absolutely. Absolutely. And all of, what you were saying, I was thinking if, somebody who's new to palliative care or who's listening to this lecture for the first time, one is you touched upon generalist palliative care, right? So do you think you could probably share some insights into if something, how, I don't want people to be like, we shouldn't get people overwhelmed to think that this is a completely, separate specialty where there's a lot of training needed. Yes, we do need training, but how they can get into what is generalist palliative care, because India's healthcare is also so diverse. We have different contexts, private, public, different tiers. So would you have any insights on those lines?
Yeah, so Archana, the best way to have everybody knowing about palliative care is to get it into the undergraduate education, both into MBBS level as well as nursing and for other healthcare workers, which is there in many countries and is coming up in India slowly now. But many of us who passed out years ago have not read about it, so we don't know. The best thing is there are many online sites and, as I said, many courses which teach us. So learn about the basics, and even if you're not giving pharmacological management, there is so much else that can be done. Like I said, breaking bad news done properly, referring to the right place done properly, non-pharmacological management for breathlessness. So many things that can be done, but you have to learn about it, or things done in a different way. At least, just knowing where to refer a person is so important. You may not be able to do everything yourself, but you should know how and where to send. So for those of us who have not read about it, there are so many information websites, there are resources available on the net. It's only when, when in MBBS, they used to tell us that the eye does not see what the mind does not know. So it's only when you become aware of the subject or what all can be done that you will start reading or understanding or learning about it and be able to help your patients. So generalist and specialist palliative care, the basic difference is that generalist palliative care can be done with a basic level of training, maybe a certificate course. If you're looking after patients with slightly more complications, you need more training. So that can be done with fellowships which are available. There are different levels of skills and competencies which are defined. And if you need more complex symptom management, then you have to go to tertiary care centers. So maybe somebody who's done an MD or a DNB in palliative medicine will be able to handle those cases. But basic things, now I'm not a gynecologist, but I know basic antenatal care. and I can handle a delivery. So that's the way it is. You know, basic things all of us should.
Absolutely. Thank you. Again, does anybody have any questions? It's just us talking at the moment. Yes,
Can I?
yes, Dr. Sudha. Yes, please share your.
Thank you very much, Savita. And you have correctly told, actually, coming to us at the early time. Yeah, I am in ECH now. ECH is, you will be knowing, actually, mainly these cancer patients, they are treated at empaneled hospitals, actually. So, when they are getting diagnosed, at that time when they come to us, even in ECHs also, because there is a lot, as you told, actually, to give them, like for any CA breast patient, soon after the surgery, lymphedema prevention. This is very, I am finding that one particular thing very essential for our ECHS patients. That is why I started a palliative care OP, because in our setup, actually, we are working from 8 to 4 and only OP treatment. So even there, I found that I can do a lot of things. So as you very nicely you told, and everything is very nicely told.
Thank
Thank
you,
you.
ma'am.
Thank you.
Thank you very much.
Thank you, Dr. Sudha.
One more myth in our department. When I was just telling palliative care, they're like, what is it? Some non-medicos were asking. It is one more medicos or someone tells nothing. It's a dumping. Dump करने के लिए उसको palliative बोलते हैं. मतलब जो कुछ नहीं हो सकता dump करते हैं ना उसको palliative. That is the understanding people have.
Yeah, so that myth is there, Divya. So, but we have to work hard with other people, you know, get volunteers, get CMEs done. It is ultimately awareness and knowledge that is going to help. And I would like to share one thing here. When I started, I know there are a lot of people, again, from the forces here. So getting forces to change is really difficult because things are very hierarchical. And unless it comes from the top, anybody trying at the bottom cannot change things. But Jilly Burns is a very renowned teacher in palliative care. She's a nurse from UK, and she once told me, never think of the work you are doing as wasted. Think of it as plowing the ground, laying the seeds, which are going to give you food 20 years later. So you may not be able to see that result, but somebody else will. So Divya, don't get disheartened. Work hard and the fruit will come 20 years later.
Thank you. Dr. Savita, would you want the quiz now, or do we share the closing comments and then administer the quiz?
I think it's almost time. It's
Yes.
It's time, 2 minutes left, so we can share.
Yeah. So what we'll do is just to summarize, I think today's session, the key takeaways maybe is, remember, palliative care follows a biopsychosocial model or has multiple dimensions. You need a multidisciplinary team, and all of your care should be directed to make sure it's patient-centered care, bottom line. And, you know, like some of us have shared experiences here, things may be a little challenging at the moment, but I think what keeps us motivated is to remember that again, there's only less than 2% or 3% of our people who need such services are there, and every tiny drop that we add will make a difference. And remember that, don't forget to check for the 6th vital sign when you're talking to any patient at any stage. And palliative care is low cost but high impact. So I think this is something that you could probably take away. And if we can have we have a short poll or a quiz that we've designed. So can I request,
so with your
Ankita,
permission, shall I launch the poll?
Please do.
Okay. So we're launching the first poll. Here it is on your screen.
Thank you.
30 seconds for each polls. And here it goes.
Yes. Please submit your answer, and then you'll have to click the submit button at the end to get your responses recorded.
10 seconds left. Four, three, two, one. Thank you. Moving to the next poll. 10 seconds for poll. 4, 3, 2, 1. Thank you. Moving to the next poll. Ten seconds left. 4, 3, 2, 1. Moving to the next poll. Ten seconds left. 5, 4, 3, 2, 1. Moving to the next poll. Here it is. Ten seconds left. 4, 3, 2, 1. Thank you so much, everyone. Here it comes to the end of the poll.
Thank you, Ankita. Can you display the results?
Sure,
Dr.
ma'am.
Savita,
Sure,
may
ma'am.
I? Yeah.
Moving to the
ma'am, may I-
first poll, launching the results. Is it displayed on the screen?
Yeah, yeah,
Okay.
it's there and it's 100% have answered correctly. Nice.
Shall I move to the next?
Yes, yes, please.
All right. Moving to the next poll. Here it is.
Yeah, this is also correctly answered. So only 4% have said hospice and cancer centers, but the correct answer is community home care, OPD indoor, and through consultation videos. So it can be delivered in a lot of ways. Thank you. Next, please.
Just a minute. Moving to the next result of the poll.
For
Here it
managing chronic cancer pain, which is a rational prescription. So the best way for managing any chronic pain is not to give SOS medication. We give round-the-clock medication. And for severe pain, we start with normal release morphine and then titrate it according to the pain. So tablet, tramadol, SOS, and injection SOS are avoided for chronic pain. Thank you. Next, please.
Here it is, ma'am.
Yeah. So barriers to palliative care in India are all of these. People think they're already doing it. It's too late. It's terminal care and lack of access to oral morphine. Yes, this is also one of the barriers. Thank you. Thank you. All of the above is the right answer.
Here it is, the answer of last poll.
Yeah, so this says advanced care planning and withdrawal and withholding of inappropriately aggressive care is legal in India. Only 68% of people have answered yes. For those who said no, I would suggest that just do go through the Supreme Court judgment that came on January 23. It is now legal in India, but there's a procedure that has to be followed. Two hospital boards, one hospital board the primary board has to say yes, and then there's a secondary board that has to say yes. Who constitutes that board? Who are the members? What is the procedure? Everything is given, but yes, it's legal. Only thing is, it has to be done in a proper way. So thank you very much for sharing that. And,
Thank you. Thank you.
And this is going to be available with Clirnet website. And lots of resources are there on the Indian Association of Palliative Care website also. And I would invite you all to go through our website, see those resources, go through them. And our emails are also there. So if there's anything else that we can help you with, any other queries also, you're most welcome to ask. Thank you very much for coming, sparing your valuable time. And I do hope it was worth it. I do hope you will go back with new concepts learned and a lot of myths shattered today. And ultimately, we hope that this 1 hour will help your patients and families. Thank you very much.
Thank you, Dr. Savita, and thank each one of you for joining us today. And thank you, Clirnet, for this opportunity. Have a lovely evening, everyone. Bye.
Thank you. Bye.
Thank you so much, everyone, for sharing such valuable insights, and hoping to meet you again on the platform very soon for the next sessions. So with all your permission, we'll conclude the session over here.
Yes.